Oh, what's up? It looks like we've got President and CEO of Jefferson, Steve Klasko, is actually here with us this morning. And he's brought a live video team with him.
So this is awesome. So listen, first of all, what I love about this, as a relatively old guy, is that you're talking about end of life. I assume it's actually to extend that. It's also great. This is our fourth hackathon. Every year it gets bigger. And I think the cool thing for me, I think the combined age of all of you starts to approach mine. So getting together with young folks is just amazing. So what I want to do is just get a feel for what everybody's doing. Who's on the wearables track? Great. Who's on the end-of-life track? How about the health disparities, zip code disparities track? Okay, so what I'd like to do is just get a little bit of a feel for why you guys are here. And what I thought, the way I would preface it is, I was thinking about this. Yesterday I got a call from the New York Times asking me to comment on Senator Warren's Medicare for All. And what hit me is that when you think about healthcare policy, we've done a lot of finding different ways to pay for a fundamentally broken, fragmented, expensive, inequitable, and occasionally unsafe healthcare delivery system. So whether it's Medicare for All or the ACA or whatever the Republicans are doing, literally it hasn't really fixed the system. And the three things that you folks are dealing with are really three of the things that I talked to the New York Times about that have to be dealt with. One is we have to stop pretending that social determinants of health and disparities are like an academic exercise. We're sitting in a city that has 6 academic medical centers, you're at one of them, and we have the greatest discrepancy in life expectancy of any city in the country. That's insane. So rather than just acting like, oh gosh, this is a new concept, we have to deal with social determinants of health, I'm really excited about how you folks are going to start talking about how we can use technology and other things to really start dealing with it. The end-of-life issues, literally we have this archaic view of how we deal with end-of-life in this country. And if you just think about what happens in this country, if somebody has had 3 strokes and is 95 and is now in acute renal failure, we have this situation where the hospital, the doctor, and the company make a lot of money to just eke out another few years of that person's life. How we deal with these issues in a way that is good for society and good for the individual is something that I'm also incredibly excited about. And then near and dear to my heart on the wearable side is my talk at Davos this year is going to be how we go from self-driving cars to self-healing humans. And the whole concept of starting to literally have you wake up and instead of just going to your Google Home or your Alexa and saying, play the daily podcast and what's the weather, literally have that wearable have sent signals, literally, if you have asthma, and basically said, here's the pollen count, here's the AQI, and here was your respiratory rate. That's not science fiction. And in fact, at Jefferson, we're partnering with a company called General Catalyst in Silicon Valley to make that a reality. So what you guys are really dealing with, and what we're really excited about at Jefferson, is that you're going to be literally coming up with ideas that we can enact and that we will enact. In every hackathon that we've done, we've come up with ideas that we are now enacting in our Jeff design. So I want to just turn it over to you. So could I have the hands of the folks on the wearables? Young lady over here, what are you excited about with the hackathon, and what are you hoping to do? Just to introduce yourself.
Oh, hi, I'm Amy Copeland. I am a fashion design professor at Jefferson, and we're working specifically on people who have temperature sensitivities and allergens related to clothing, and trying to come up with good solutions to make clothing more comfortable, and especially with climate changes, we're experiencing higher temperatures than we ever have in the past. And I think we need to change how we dress in order to be comfortable.
Fantastic. And for those of you who don't know the Jefferson story, we are a 195-year-old academic medical center that merged with one of the top fashion design universities in the world. People thought that was nuts when we did it, but exactly what you're doing is why we did it. Who else is on the wearables track?
Hi, Dr. Klasko. So my name is Sonia, and I'm interested actually in the allergen field as well. And so early detection of anaphylaxis by sensing histamine, increased histamine in the blood flow.
One more wearables person. Anybody on this side? The well-dressed man with the tie.
I am Peter Dedao. I'm a biomedical design engineer, so I spend a lot of time with other engineers and a little bit less time with patients and doctors. So it would be really great if we can sort of combine those resources and come together specifically to improve patient outcome. I'm working right now on a wearable to specifically administer antibiotics at a more achievable rate and to incorporate that with other metadata.
Thanks, and that's one of the cool things about this, and actually I guess every hack, is that we tend to get cloistered in our own thing. Doctors talk to doctors, engineers talk to engineers, and getting folks together is what's really great. Who's on the end-of-life track? Let me run over there.
Very much. My name's John. I'm on Team 31 with my brother Mark and my good friend Jeff. We're working on perimortem communication. I work in an ICU across the river, and in the end stages for most folks that we see, there's really poor understanding by families and individuals of what their options are. And when a provider says the prognosis is poor, that doesn't read, that doesn't mean a lot. And there's a big disconnect between when a clinician says, most of the time, this is what we see, and what a patient or a family member hears. When the patient hears most of the time, they think all the time, or they think the most optimistic circumstance.
They hear the bad news.
Yeah.
Tune out everything else.
And they're triangulating to try and find something that is going to validate a hopeful narrative. And so we're trying to translate between clinicians and patients and families in that window and provide some tools for people to understand one another better.
So this will be direct to consumer.
This will be almost like the language line, you know, where a provider will pick up one end of the phone and someone speaking a different language picks up the other and someone communicates between them. And using some of the technical platforms to facilitate that over the course of the end-of-life process.
And you know, one of the things that we're looking at, and this I think fits at Jefferson, is a whole different way of how we select and educate providers. Because when you think about it with AI, it used to be all about memorizing stuff. That makes zero sense when everything's on your iPhone. So starting to select folks that are better at that so you don't need the Google Translate quite as much, I think will be another piece. Who else is on end of life? Did I see somebody? Okay. You guys are making it really... Who was it? Who raised their hand? After all that, somebody better talk. Okay, we'll get both of you.
So my name is Amna. I'm a doctorate student in strategic leadership at Eastfall, and I have my two team members who are designers. So we were also pitching on the problem of communication between doctor and the patient's family when it comes to the sudden death of a child. And we're looking to combine an innovative way of communications for pediatric care and patients' families.
That's fantastic. As an obstetrician, there's just no way that any of us has been trained to do that. So that's going to be a really exciting project. How about you? Oh, you were just nodding. Okay, got it. One more. All right. Well, that's the end of life section of this. So, how about the healthcare disparities piece? Okay, good. Oh, good. Oh, this is awesome. It's right where I am. Okay, both of you guys. Why don't we start over here?
Hi, this is Jane. I'm a data scientist of Jefferson. So we are working on a predictive engine to take consideration of all available data to predict when, where, and to whom bad events will happen. We're going to design an app to dispatch relevant parties like volunteers and social workers to either prevent the bad events from happening or reduce the harm. So the use case we have in mind is like people getting homeless, opioid overdose, and food insecurity.
Good morning, Dr. Klasko.
How you doing?
Good. Hi, everyone. My name is Chris. I'm a second-year medical student at Drexel, though. Sorry about that.
You obviously couldn't get into Jefferson.
Yeah, no, it was a fantastic, yeah. Not quite good enough for Jefferson.
Only kidding, only kidding.
So the
Just said that to the guy at Penn over there.
So the problem we're trying to solve is basically twofold. Food deserts. So in Philadelphia, we have a really bad problem with food deserts. The fact that we kind of heard earlier today that if you live in one area, you might have an average life expectancy about like 86 versus another area a few miles down is a lot lower to around 60. And part of that has to do with the food that we eat and the nutrition because it leads to a lot of different comorbidities and illnesses from the food that we eat because in food deserts, we're not really able to get access to those fresh fruits and vegetables. And the other problem is we waste a ton of food in this country. We waste about 730 stadiums of food every single year in this country. And we're trying to find an innovative solution between right before we throw away these foods, if we can get them to these food deserts, that way individuals that live in these food deserts can get access to these fresh fruits and vegetables, then we can solve really two problems at once. And honestly, if we can solve this, then an ounce of prevention is worth more than a pound of cure. So if you prevent this earlier on, we don't have to go treat that heart attack later on in the hospital.
So you know, that's fantastic. And actually, one of my commencement speakers last year was an individual from Ethiopia that did something like that with soap. Because they were so soap challenged there, it was like a big deal, you know, a bar of soap. And he went to an American hotel for the first time. And, you know, he had the bar of soap, he used it for a shower. And then he woke up and there was another bar of soap. And he basically took what, I forget what the number was, but 1 million tons of soap that gets, you know, basically thrown away and recycled it exactly in that thing to send to places that are challenged that way. And by the way, getting back to the wearables piece, our other commencement speaker was a guy named John Scully, who was the CEO of Apple, got brought in by Pepsi to babysit Steve Jobs and try to turn it into a real company. And he had a great comment that I think the wearables folks ought to think about, because he said, you know, you guys have to stop talking about technology like telehealth or wearables. He said, we don't talk about telebanking. We don't get up in the morning and say, I think I'll telebank today. It's just that 90% of banking went from being incredibly inconvenient in a bank, and people used to kid around that the two like worst customer service things are banking and healthcare, to the point where that's not the case anymore. 90% is at home, can't deposit a check at 5:30 in the morning, you're upset. So how we start to think about these things of getting things to home, and then getting back to the disparities piece. One of the debates that I was in is this technology and consumerism like wearables and telehealth just going to increase the disparity? And the answer is it doesn't have to if we don't let it. So one of our largest users of Jeff Connect, and we have 140,000 visits on our telehealth platform, is Project Home, which is this very large homeless community in Philadelphia. And when you think about it, a lot of them don't have cars. If they have cars, they certainly can't afford to park at Jefferson or Drexel and Penn, but they have phones. And if their kid has an earache, that might be the easiest way to deal with it. So I think how we start to think about this in changing the whole healthcare ecosystem is incredibly important. One more disparities person?
Thanks, Dr. Klasko. My name is Alfred Atanda. I'm a pediatric orthopedic surgeon at DuPont Children's Hospital down the way, affiliated with Jeff. And as an orthopedic surgeon, one of our big frustrations is that it's always hard to get people in to see us because we're kind of at a big, large academic center, but people usually go to the urgent cares and low-lying ERs and that sort of thing. The process of getting my expertise to those places is very cumbersome. It's very labor-intensive. It's very costly. It's a very poor satisfier of patients, moving them to us as opposed to moving my knowledge to them. So our team is hoping to kind of reimagine that process, similar to what you all have done with telestroke. And really having kind of that spoke hub model where people can stay in their medical homes, get access to expertise from someone such as myself with as little inconvenience to them, and helping to facilitate how we streamline and triage people, bringing them into our center.
Well, thank you. So look, I'll sort of end because I want you guys to get started. This is just incredibly exciting, and I think the concept for us of actually starting to solve these problems is really going to start in places like this. It's not gonna happen in my executive offices. It's not gonna happen with the 55-year-old physicians or nurses that are used to doing a certain thing way, and it's not gonna happen in the top 20 academic medical centers. It's gonna happen down at this level. And the other thing I'm excited about, especially with the health disparities piece, is you guys are giving me a lot of ammunition for Thanksgiving, because my daughter over there is a PhD in public health, and her postdoc at Brown is all about the psychosocial barriers that exist to everybody getting access to whether it's HIV prevention or cancer care. So I'm excited to have some new knowledge that I can sit at the Thanksgiving table and look sort of smart. So guys, have a great time. This is meant to be fun. Again, this is both fun, and when I get the information and get all the stuff that you've done, we really work with our colleagues to enact what you folks have done, and we look to create businesses and new models for Jefferson and other places in Philadelphia and beyond. So thank you for spending your Saturday with us, and just have a great time and hack away. Thanks.